Welcome to the HFMA Colorado webinar series. We want to take a moment first to recognize some of our annual business partners who not only provide financial support to our chapter, but also share their knowledge and their expertise through speakers and presentations just like these. Their support allows us to operate our chapter and bring our members quality education and resources. We hope that you would always take a look at them first when your organization needs services or support. For today's webinar, we will use the Q&A box located at the bottom right of your screen. You can also input any questions you have in the chat box. We will try and monitor those as we go through the presentation, as well as address any remaining questions at the end of the presentation. A few reminders: certification is now included with your all-inclusive HFMA membership. If you've been thinking about getting certified, today or now is a great time to look into it. All certification training materials and the exams are included. Certifications can be completed online on your own time and at your own pace. There's no need to find a testing site. Exams are timed but not proctored. Anyone who needs additional assistance with certifications, reach out to us at the chapter for additional support. Couple resources: if you want to take a screenshot or photo, you can look online at our national website, and our Colorado chapter contact for certification is Eric Wilberg. His contact information is right there. And with that, I want to welcome Mary Devine for today's webinar. Mary Devine is the Senior Director of Revenue Cycle. Her main responsibility with Bessler is to oversee the Transfer DRG product line. Mary has over 25 years of experience in healthcare financial management and has a wide knowledge of all components within the revenue cycle, as well as a strong clinical background. Mary holds a bachelor's in accounting from the Pennsylvania State University and is a registered nurse. Please join me in welcoming Mary.
Thank you. So today I'm going to talk about the COVID-19 impact on the Transfer DRG review. And I guess when you talk about the punchline is that in fact, COVID-19 is impacted by the transfer rule. When you look at the diagnosis codes that COVID-19 is coded with, they wrap up to the DRGs for respiratory, and those respiratory DRGs are in fact impacted by the rule. So providing they meet all the other qualifications of the impact of the rule, they would in fact be impacted by the rule. So what I hope to accomplish today is I want to provide a quick reminder, refresher of what the PACT policy is. I know we're all familiar with it, but sometimes a general refresher is always great. And then next I will talk about some of the public health emergency impacts on Medicare services, some of the billing things that they've added in, and the payment changes that the waiver has had. And then finally, I'm going to marry the two and talk about where I think and where, you know, I've had the opportunity to look at some data post the pandemic and see where I'm seeing some of the changes come into play and some of the impacts that COVID does actually have on the transfer rule. A lot of what I'm going to talk about is going to be a refresher for the transfer rule. And I really wanted to revisit some of the things that I've talked about, and not only talk about how the pandemic has impacted the transfer rule, but throw in a little bit about the OIG and where their reviews have come in as they did some reviews this past year on the transfer rule. So as I mentioned first that I wanted to do a quick run through of what the impact is and how accounts are impacted. And a real refresher, if you weren't in healthcare back then, the transfer rule came about in the late 90s to stop Medicare from paying for care twice. And it started out with 10 DRGs because Medicare said, well, you know, I'm paying for the patient to have their hip replacement in the hospital. They're getting the full DRG. and then they're going off to the skilled nursing facility. At that time, it was a skilled nursing facility and not home care. And then they're receiving additional care. So they really felt that providers were getting double paid for it. So there was really came into play when there was such a focus on the length of stay to decrease that length of stay. So, you know, the ultimate rule was the post-acute transfer rule, or as we know it today as the PACT, is if a patient was discharged below the geometric mean length of stay and the discharge status on the claim indicated a transfer to post-acute care, then the hospital is entitled to a per diem payment amount and not the total amount of a full DRG payment would provide. So the impact of the rule to providers is that difference between the full DRG and the per diem payment. And, you know, over the years that I've been focusing on the transfer rule, we really see that the impact of the rule can affect as much as 15 to 20% of your Medicare discharges. Certainly some are higher and some are lower. And one of the effects or impacts of the COVID is that certainly the length of stay has impacted. So if you are in an area where you see a high volume, especially back in April, May, and June, high volume of COVID patients, most likely your impact of the rule is going to shrink because your patients are back then had a much longer length of stay. So once they're up over that geometric mean length of stay, there is no longer impact of the rule. If you are not in an area that had a high volume of COVID patients, what we're finding is there is more impact of the rule because those providers were moving patients in and out rather quickly. Again, hoping to keep them out and keep them safe from COVID. So we're seeing a higher impact of COVID. So it really depends on where you were located and the volume of COVID patients you were seeing. And from an average perspective, the impact of the rule is about $3,500 per patient. So again, with every account that's impacted by the rule, you're going to see about a $3,500 drop in your Medicare reimbursement. And it doesn't take a lot of math to figure out how much that impacts your facility from a reimbursement perspective. And with, you know, one of the biggest things that we've seen from a COVID impact is the drop in discharges. We have some providers that we've seen, you know, 40, maybe even 45% of their normal discharges. We're seeing that drop significantly. And so, you know, when you think about the impact of the rule, that is a lot of change in your reimbursement from the full DRG to the per diem. And, you know, honestly, the transfer rule is not that nothing that should be taken lightly and always deserves a deep dive and a second or third look under the hood to make sure that you are getting all the money that is yours. And I think in light of the PHE, there is going to be some additional impact of the rule. And certainly the rule is going to be a little bit more difficult to determine whether the account should be impacted by the rule or not. So right now, there are 280 DRGs impacted by the rule. I did want to point out that if you're looking at accounts from 2020, there were 278 DRGs impacted by the rule. That was the first drop that we've seen in a long, long time. It was at 280 DRGs for quite some time, and and then there were 278 for 2020. But as we sit here 5 months into 2021, we are back up at 280 DRGs. Medicare added in 2 new DRGs as it relates to hip replacements. Here's a list of all the discharge status codes that are indicated transfer versus a discharge. So if you put an O2 on it, indicating the patient's going to an acute care, that is indicating to Medicare that that patient was not in fact discharged, that there is a transfer and there is a continuation of care, and you would be impacted by the transfer rule. And then just keep in mind that anything with a discharge status code of an O2 is in fact impacted by the rule, providing it's below that geometric mean length of stay. Once it goes up above that geometric mean length of stay, Medicare says you have really utilized all those resources intended in that DRG payment, and you're entitled to the full DRG. So once you get up above that, again, above that geometric mean length of stay, there is no impact of the rule, whether it's coded a discharge or a transfer. And the two newest ones, and at this point, they're not all that new, is 50 and 51. Both of those were added in fiscal year 2018. So if an account is coded or 50 or 51, Medicare considers that continuation of care, even though when you think about the intent of hospice is not really to treat, but to comfort. So it was argued for quite some time, but it lost, and those accounts are too now impacted by the rule. Of one final note, when you talk about the impact of the rule, if by chance you are a sole community or you are critical access, you are basically reimbursed cost, and there is no real impact of the rule, where an average impact of the rule for IPPS facilities is $3,500. If you are reimbursed cost, the reimbursement is minimal. There is still some impact, but it's I think it's about somewhere between $125 and $175. So the impact is certainly minimal if you are not an IPPS facility. So talking about the COVID-19, and I think at this point we were hoping we wouldn't have to talk about it in 2021, but nobody needs a reminder that it is still here. So back in almost a year ago, the president called a national emergency, and the Secretary of Health and Human Services called the public health emergency. And with that, under Section 1135, waived certain requirements as it relates to the conditions of participation for Medicare, Medicaid, and CHIP. And although we talk about this from a US perspective, this is a global pandemic. And when I speak of the pandemic and the public health emergency, it is specifically speaking about it here in the United States, as well as really being specific to the things that were called in the 1135 waiver as it impacts Medicare. And this was called on March 13th, again, almost a year ago, and it went retro back to March 1st. And it is still in place. Right now, there is not any indication of when the pandemic will officially end. People talk about the fall, but nobody knows at this point. And as we moved through the past year, there have certainly been things that have been added to the 1135 waivers. And as I talk about some of the original waivers, I also will talk about more recent additions to that. And the biggest focus of the waivers was to keep patient care at a focus and making sure that any patients that needed care had access to it. And I always like to say the biggest thing you see through it would be the patients over paperwork. So get people more focused on patient care versus focus on completing paperwork on a timely basis. And the waivers did not include the CARES Act for the distribution of $100 billion to the providers that was given out earlier last year. And that the distribution of that was really based on the revenue that was in the Medicare cost reports that were filed the year before. So as I said on the previous slide, the 1135 waivers was a blanket waiver, and it was retro back to March 1st. And these waivers, they initially were to stay in place for 60 days post the PHE. But again, at this point, we have no idea when the post PHE is. So these are still in place. And just to talk about some of the impacted areas, documentation was impacted, care planning, discharge planning, staffing requirements, reimbursement. And these were rolled out for all hospitals, psychiatric facilities, critical access hospitals and cancer centers, any type of SNF, inpatient rehab, hospice, and the dialysis centers were one of the more recent additions to the waiver. And that was really placed from an additional funding perspective, really encouraging patients to receive their dialysis at home or to receive their dialysis in the skilled nursing facilities versus traveling to that dialysis center. Outpatient and physician services were impacted. We see that as we talk about telehealth and some of the places that patients could receive care. And then LTACs were not excluded from this as well. One of the biggest things when you talk about hospitals from an initial perspective is they eliminated all elective non-emergent surgeries, and those were suspended, and everything moved to telehealth for a period of time. And since then, over the summer, those procedures were brought back. I think one of the unfortunate parts is, people, especially Medicare patients are still afraid to go and receive some of those elective procedures. And, as we look at admissions post 4/1 and into, late 2020, we're still seeing some of that impact in the volumes of Medicare admissions and discharges that we continue to see. Again, one of the other things that happened from an EMTALA perspective, patients were being allowed to be screened in alternate locations through a telehealth so that they did not have to come to the hospital in case it wasn't an emergent situation. Across all the providers that I mentioned, the specifics for the waivers are not the same, but what is the focus, as I mentioned before, is the patient's over paperwork and making sure that patients have access to care when they need it. And if you haven't read these waivers, you can do so on the CMS website. And what's included there is all the updates that continue to come out as it relates to the pandemic. Some of the updates that come out, are certainly more focused on the distribution of the vaccine and making sure anybody who wants to get the vaccine can get the vaccine. But we know that it takes time to roll all that out. So really, most of the waivers, or if not all the waivers, either increase patient care space or minimize administrative functioning requirements. So with all the alternate care sites, the ACSs that came out, those were to increase the spaces where patients could get treated for, tested, or they could receive the vaccination. So when you think about those parking lots where patients drive through, those are actually extensions of the hospital and are being billed as if they were the hospital. So just some things to consider when you think about what went into the waivers. And then the other thing, looking at the care planning, just an example of what the waiver did to minimize paperwork. They really minimized the timing and the requirements of the care plan for the patient, with the caveat that patient care is not impacted. So some of the more recent additions to the waiver, when it came out back in March, the biggest thing is the 20% increase to the IPPS DRG for COVID treatment. So as long as one of the diagnosis codes, either be 9729 if it was before March 31, or if it was post April 1, it was the U07.1. As long as those codes are on the bill and it is an inpatient stay at an IPPS facility, then you would get 20% on top of the standard DRG. So, and that is included with the impact of the rule. So if the account is impacted by the rule, you are still entitled to that 20%. Your per diem would be 20% higher. And then of course your full DRG would be 20% higher. And one of the biggest things when you talk about getting that diagnosis onto the claim, it's kind of a conflict between coding from a test result and a physician clinical conclusion. So right now, in order to diagnose a patient with COVID, you can go right off of the lab test. So when you get the lab test back, you can code that as a positive COVID, as long as that's how the lab test comes back. Prior to COVID, nothing could be diagnosed without the intervention and conclusion from a physician. But so that's just a little kind of a conflict of what coders are used to and what they can do with COVID. And again, there's just no update on how long this will be in place. And the other thing that was added, there were 3 new condition codes that need to go onto the claim to indicate whether it was a COVID claim or not. So if it is an 837 or 1550, you want to put that DR on there, disaster related. So that indicates this is a patient with COVID. This has an impact of the COVID. Maybe you're using an alternate care site. Maybe you're transferring a patient to a SNF because they have COVID or whatever the case might be. If it is a 1500 or a physician claim, you want to have a CR, which indicates a catastrophic related patient, and you want to include that on there. And then finally, this is one of the real new ones that came out, is the CS, which indicates cost sharing. And this actually came out in 2010 and was due to the oil spill way back when, if you can remember. And it was now brought back due to COVID. And this indicates to CMS that the 20% should be waived for a copay or any outstanding deductibles or co-insurance amounts. That will be waived with the CS. So there is absolutely no cost sharing for anything as it relates to treating or diagnosing COVID patients. So as we walk through points of the waivers, please keep in mind, as I mentioned before, this is designed to keep patients before paperwork, as I mentioned probably 3 or 4 times already, and ensure there is an adequate space to provide the care as well as staff to provide the care. So when we look at acute patient transfers, hospitals without walls, this means that it's exactly that. It lends into the alternate care sites, and you can use temporary space to help treat patients. I utilize I use a cafeteria as an example, or whatever the case might be. You're utilizing space that was shut down, that didn't have any licensed beds in it. You still have to be associated or as part of a licensed Medicare provider. You can't just open up a non-clinical space and start treating patients. You would need to be certified, but you can do that under the premise of your existing certification. And this would allow you to transfer patients to non-acute distinct parts for acute care. An example would be acute to rehab or acute to psych. But first off, these patients have to have COVID, or you have to be moving patients because there are COVID patients involved. And it's really designed to help isolate COVID patients and cohort COVID patients, and to always designed to stop the spread. And of one final note, if you're moving acute patients to a psychiatric unit, they have to have all the requirements of an acute care unit. So with oxygen and just as an example, just all the technology that has to be there for an acute patient, that would have to be there in the psych unit. So again, you can't move patients that if those requirements aren't there to treat an acute care patient. And then as you transfer those patients and move these patients around, you want to make sure that the status is maintained, because the intent was not that the patient would be discharged and a new admission would start, but that they would maintain that acute status. And one final note, think about cost tracking. And when you look at your cost report down the road and gathering your patient beds and where patients were, you want to make sure that you include any alternate care sites. And one other thing that's they're allowing an expansion of is the acute care patients at home. And this is also, again, not intended to be a discharge, but treat patients at home. You already have to be a licensed provider of acute care at home, but they're allowing you to expand on that to utilize it more. Home health. So again, all focused on patients over paperwork, and just the common theme throughout. They extended the OASIS completion timeframe. Certifications can be done via telehealth. And there's certainly recertification flexibility. A lot of that was difficult with home health agencies. They would struggle to get the recertification done, and the claims would be held up. Well, now that's waived to allow for more time. And homebound status now includes a diagnosis of COVID. So if they have a COVID diagnosis, this would have them as confined to home and would be entitled to HHA. If a patient is quarantining because they were in Florida or traveled outside of their state and their state requires them to quarantine, or if they came in contact with someone in quarantine, that does not count as homebound. So just make sure that the understanding is there. And then when you look at telehealth will count as that care within the 30-day period of care, but it is not a billable service. So just want to make sure that telehealth is billable in a lot of situations, but for home health, it is not a billable service. You would need to go to the home in order to actually get that onto your bill and count as actual service. And then the wrap time frame was lengthened. And in thinking of the transfer rule, there will be more patients confined to home and entitled to home care if they were discharged home quicker and impacted by the rule. But then there's the concern of, do patients want people in their home? And so, what we're finding is that we are finding less patients are actually being transferred, even though they would be entitled to it, because patients are not wanting people in their home. So we are seeing a little bit less of patients being transferred to home health. And as you talk again about the transfer rule, keep in mind that providers will have a little bit longer of time to get that initial claim in, that wrap in their intent to bill. So you want to be careful if you're looking at whether the patient actually received home care or not. As you do a review for the impact of the rule, you want to make sure you give the home health agency time to do what they need to do. Skilled nursing facilities. Again, patients over paperwork. The MDS timeframe requirements were lengthened and less stringent. The pre-admission screening was removed, and the annual reviews have been suspended for now. The required 3-day qualifying stay is removed. It allows providers to free up beds in the hospital and get patients out who do not have COVID. And it helps keep, again, the cohort and keep nursing home patients free from the COVID. There's been a lot of focus on CMS with that. And one of the most recent updates that came out is the benefits expired is removed for patients with COVID to be treated. Now, keep in mind, even though the 3-day qualifying stay is removed and the benefits expired is eliminated, medical necessity has not been removed. And so it doesn't guarantee treatment. The patient still has to be medically required to have those types of services they're getting. And again, I always like to throw in the impact of the rule. As we think about the PACT rule, it is critical to understand the level of care the patient is medically dictated to have, as I mentioned. And there are certainly risks of improper coding. If a patient goes back to the nursing home, whether they were if they were not in a skilled bed, were they receiving skilled care or not? So you need to be certainly aware of that. Just quickly go through some of the other post-acute transfers. And again, as we talked about, the waivers really impacted all providers. Long-term acute care, the length of stay expectation, used to be that if the patient was going out to a long-term acute care, the expectation was that they would be there for 25 days. Well, that was waived. And then LTACs that are currently seeking certification are now included and can do billing. And then there is a reimbursement impact due to the site neutral, and that was taken care of in the CARES Act. And then also when you look at the inpatient rehab, kind of similar, but different to specific rehab requirements. The 3-hour requirement of therapy each for 5 days a week is waived. And that means, again, more patients will be eligible for inpatient rehab and get out of the hospital faster. And patients can be relocated if needed, if there's any reason for them to be moved because there is a rise in COVID cases. They could move those patients without changing the level of care. And so, again, patients could likely be moving more due to the cohort of the COVID patients or the onset of the COVID. And this will be part of reviewing for the transfer rule. All right. So now I'm going to talk about what I like to call 5 compliance pitfalls as it relates to the transfer rule. And these have always been my 5 favorite 5 compliance pitfalls as it relates to doing the DRG reviews, transfer DRG reviews. But when we look at some of the things I've talked about from a COVID impact, these are certainly heightened and more of a concern as we look at claims that are post March, April timeframe discharges, and certainly at risk of being coded incorrectly. So relying solely on the common working file, the lack of a claim in the CWF, and now we know it as the HETS, HETS utilization should not be whether you determine whether the patient had post-acute services or not. And, certainly as we head into some, again, looking at accounts that are impacted with COVID, there's a much larger risk of the patient utilizing services and not being billed to Medicare. And you want to make sure that you reflect that discharge status code appropriately. And timely filing is not waived, but there are, if benefits expired, potentially benefits expired for a SNF patient, and you can't see the claim in there. So again, you just want to be careful when you consider what the discharge status code is prior to updating that claim. A compliant discharge status validation process should always include review of the CMS utilization, a clinical review, call to the post-acute provider, and call to a provider rep at the MAC. All of this is just to ensure that when you update that discharge status code from a discharge status code of what looks to be a transfer and change it to an actual discharge, and that claim will no longer be impacted by the rule, you want to make sure that your claim is correct. And you want to, so there's a lot of things, as we talked about the COVID, what you want to consider in some of the waivers. You want to make sure that you consider any of your ACS, any of your alternate care sites. Are you utilizing space for acute care that you wouldn't typically, and is the claim coded right? So if you don't review the medical record and you don't consider all those things, you really could discharge a patient or maybe transfer a patient that shouldn't have been. And placing the calls out to the post-acute care provider when we think of patients moving around due to cohorting SNF patients or rehab patients, you want to make sure that you're calling there and confirming what level of care that patient provided. Maybe because the patient was going to a SNF, it was coded in 03, and when they got there, they were really just, they were a long-term care and they were in a SNF bed because that's all that was available. Okay. So on the previous slide, we talked about a lack of clinical review, and I just think that you must read and understand the reason, intent, purpose of the transfer. Just because somebody was in the psych unit, it doesn't mean that they were intended to be in the psych unit. If just because the patient was in the rehab unit, maybe it was an O2 and there should have never been a discharge. And I think really that there is more risk of non-COVID patients being impacted by the rule and mistakenly showing a transfer when they really shouldn't have. And again, keep thinking of alternate care sites. And maybe as a provider, you didn't have a high volume of COVID patients, so you won't have all this, but still, you want to ensure that that discharge status code is correct on your claim. And just 2 other points that I think are so important when you go back and you re-review your claims that are in fact impacted by the rule. And this is really not an impact of COVID or not, but just certainly important. And the OIG has been focusing on these. So the use of condition code 42 with a discharge status code of 06 entitles providers to the full DRG, but bears the risk of overpayment if clinical resources are not involved to determine the appropriateness of the coding. As we talked about, more patients will qualify for homebound, confined to home, and make sure the appropriate code is on the claim. And I think over time, as we head into looking at claims from late 2020 and early 2021, I think patients more and more are understanding, it's important to receive their post-acute care, and we'll see an increase in the patients that are homebound. So you just want to make sure that you are coding those appropriately. And then, I can't say it enough. I know I said it plenty of times. Inappropriately or not coding a discharge status code 02 is certainly either an underpayment or a potential rejection delaying the payment. And again, keep in mind that all DRGs are impacted when you use condition code 02. And if you're sending someone to an alternate care site for follow-up work, or I'll use a COVID recovery center to do follow-up work, you don't necessarily want to code that in 02 because potentially the patient is not going to be admitted. And this is just a continuation and highlight I mentioned previously. You must verify with post-acute providers. You have to place that call. You have to speak to someone. And utilizing clinical resources to do that is also, making sure that someone, clinical to clinical always helps with verifying that. And if you don't, you could have errors or rejections on your claim. And even if you are a sole community or a critical access, your discharge status code still has to be right. Your claim still has to be right, even though it might not fully impact reimbursement. Your claims still have to go to Medicare coded appropriately. So to confirm if the patient was a transfer or a discharge, you must investigate who the receiving entity was intended to be and what, if any, care was provided. With the change, again, with the changes made to COVID-19, a retro review is important, and you should utilize some clinical resources and place some calls. One of the waivers was the discharge planning, and without impacting care, and discharge planning it was minimized, the documentation of it. So again, it might take some digging and some clinical research to understand really what was intended for that patient to do after they were discharged from the hospital. These are some questions that I would highly recommend asking post-acute care providers, but certainly not limited to, the ultimate goal is to get to the level of care of that patient. Was it a level of care that was covered by Medicare or not? And it is a true transfer, or was it a true discharge? So just some of the ones that I recommend: was the patient admitted on the day of discharge? Was Medicare billed for the services provided? Was the patient in a licensed Medicare bed? And what type of care did the patient receive? And in asking these questions, certainly reviewing the EMR is always a key piece of this as well. And this is not specific to COVID, but certainly it is a little more sensitive as we talk about some of, like, home health. They now have longer to get their wrap in, so you might not see evidence of home care for a little bit more extended of a time. So beginning the retrospective review too close to the date of discharge might cause an incorrect discharge status code, because post-acute care providers must have enough time to submit their claims before a retrospective review of transfer DRG underpayments, overpayments is completed. So again, you don't want to risk being underpaid or overpaid and beginning too close to the date of discharge. What is the appropriate time frame for you? Depends on the type of information you have access to. If you have an owned home health agency, well, beginning within 2 weeks might be just sufficient enough as you can review the chart. So it just depends on the type of provider that you have and what you have access to. Post-acute providers can submit claims up to 12 months after the service is performed and still remain within the time frame. So again, when you're reaching out to something like a SNF, it could be 12 months plus 60 days before you see a claim from the SIF. So just, again, making sure, setting the light on the concern of utilizing the CMS information is key. No overpayment review. That really should be a question mark or an exclamation point. providers are potentially overpaid on transfer DRGs 15% of the time. Matter of fact, CMS has come out and said our edits are incorrect 15% of the time. So that means that you code something in 01 and it's going to pass through because CMS doesn't pick it up in DDE, and they're not going to marry the utilization, and you're going to get paid even though potentially that patient received home care, potentially the patient received SNF. So you just want to make sure before the OIG comes in that you are not overpaid. And these can result in insufficient documentation. Maybe there was no evidence that the patient was going to go home and receive home care. It wasn't noted in the chart. So you coded in 01 and you got paid. There's always the risk of clerical errors. I'll use 42 and 43 condition codes as an example. A lot of times when a new system gets put into place, there's that accidental of 42s going out on all 06s, and that's an error. The timing of processing claims is always that risk. Did you get all your claims being processed before home health even submits theirs or talks about submitting theirs? And then, as we talked about on all the previous slides, the incomplete validation of the discharge status code is always that risk of being overpaid. And I don't think this is news to anyone, but federal law requires providers that discover overpayments to self-report and initiate an overpayment return with their MAC. And the overpayment reporting has not been extended due to the waivers. And if you pick up on a claim that is overpaid, you can simply just adjust that within your DDE and take it from, make the claim in an 01 to an 06, and that will trigger Medicare to take the full DRG back and pay you the per diem. So, taking a step back and looking at what the OIG has done, they really moved in heavy in late 2019 as it relates to condition code 42 and 43. And it was really focused on saying that with discharge status codes of 06, claims were overpaid because they had a condition code 42 or 43 on them, and vice versa. They did the exact same. There were a lot of providers that they found to be underpaid because the lack of condition code 42 or 43. And I think that it really was not overly successful for them due to, they found as much underpayments as they did as overpayments. So they stepped away from looking at the 42s and 43s. And the 42s are really a difficult process. And they, when you talk about an involvement of a clinical review, those are key from a clinical review and speaking with a post-acute care provider. But the condition code 42 was never intended to be a one-to-one from a diagnosis code perspective. It's supposed to be an overall care of the patient. And so they took that off the OIG work plan. And even as we look at the work plan for 2021, the transfer rule as a whole still remains on the work plan, but they're really focused at 01s and 04s versus the condition code 42s and 43s. So what should you be doing right now? Certainly always recommend a retrospective review on discharge status codes and making sure that your claims were billed correctly. Through all this, whether you're underpaid or overpaid, they have to be correct. And that's the biggest thing with Medicare. We all know your claim has to be correct. Have you had an OIG audit? Find out if they've been there, find out what their findings were, and maybe that can target what you should be looking at from a retrospective review. Have, as we talk about the COVID-19 waivers, were there any locations that you need to be aware of? And I always suggest determining the financial impact of the rule to you as a provider. And when you think about the drop in volumes, as we've seen post 4/1, every dollar counts, and you want to make sure that you're getting everything that you're entitled to help cover some of the losses that we see due to the lack of admissions. That's it that I have. Does anyone have any questions?